So we are good to go. Right. So thoracic and lung abnormalities. Like I was saying, I wanted to apologize that I did not have enough time to put the images. So I'm hopefully, if we don't finish today, next week this presentation will have the relevant images, and I'll run them. I'll run through the images for you next week, so that you can imagine, or you can have some pattern recognition. But most of the conditions that you will hear today, we have already experienced them in the clinic. Those who have assisted the fetal defects clinic. So yeah. So what we want to do here is to transmit the natural history knowledge and also the counseling messages, so that people know what to tell patients. Because knowing a condition and knowing what to tell patients are two different things. So bronchial atresia, it's a condition which is not very common, 1 in 100,000. So that means in Zimbabwe, where we deliver around 400,000 women, you can potentially see just 4 of them. So it's not very common. So even if we haven't seen one, I'm not sure if we haven't seen one, but it is normal not to meet one, considering that we don't see every woman in Zimbabwe. So how do you suspect it on ultrasound? Normally, I think we once saw one, yeah, from my memory, I think one. So you see enlarged hyperechogenic lungs with dilated bronchial tree, which result in mediastinal shift to the contralateral side. That is bronchial. What is a bronchi? A bronchus is that division that comes out of the trachea. The trachea divides into 2 bronchi, the right and the left bronchi. So that is what we are talking of, the bronchi. So if they are obstructed, the lungs, the side which is obstructed will enlarge and will become hyperechogenic. And this will cause the shifting of the midline to the other side. The baby may have ascites, which result from central venous compression. Whenever ascites is present, this is a bad prognostic marker. Then in terms of associated abnormalities, let me make this larger. The incidence of chromosome abnormalities is low. So in these women, there's an option not to offer karyotype if the condition is isolated. Then a detailed ultrasound scan examination has to be done to rule out associations. Then in terms of follow-up, every 4 weeks to monitor the evolution of the condition, especially the appearance of the ascites. Oh, what have I done? Okay. This is coming the PowerPoint. I'm sorry, I've just changed to PowerPoint, so there may be some freezing of the slides on your side, but yeah. So let's see. I want to duplicate the display. Right. So let's continue. Right. So in terms of the delivery, a hospital with the neonatal intensive care and pediatric surgery is what is recommended, and the delivery timing is around 38 weeks. The method of delivery normally it's better to offer cesarean, because these babies will have difficulties in breathing because one of the lungs is obstructed. So they will need resuscitation and intubation immediately after birth. That is the reason why cesarean section is the preferred mode of delivery here. The prognosis, unfortunately, the perinatal mortality is very high for this condition, and there's no increased risk of recurrence. Because of the high perinatal mortality especially for babies who have developed ascites, sometimes discussing termination of pregnancy is a viable option for the couple with this kind of a baby. Then we do have bronchogenic cysts. Again, not very, very common, 1 in 50,000. Even in fetal medicine terms, it won't be very common because in Zimbabwe, we'll probably come across 8, the whole country in a year. It is not very common. Normally, what you see on on ultrasound, you may see a cyst within the lung area, and there is no increased echogenicity around the cyst. So if you see cysts, which are normally singular cysts, those are bronchogenic cysts. So any cyst you see in the lung where there's no increased echogenicity around it is a bronchogenic cyst. This is very important. There are other cysts we are going to discuss, which will result in increased echogenicity around them. So always remember that the echogenicity, the echo density has to be normal around the cyst. And normally these cysts are central because they are originating from the bronchus, which are normally central structures within the hemithorax. So the location also matters for you to say this is a bronchogenic cyst so that you distinguish it from the other cysts. The incidence of chromosome abnormalities and genetic syndrome is not increased. So for this couple, there's an option. We don't necessarily have to offer them karyotype if they have a bronchogenic cyst. Detailed ultrasound scan examination is highly recommended to look for associations. Always remember the presence of one defect will mean that you have to look for the other defects. Yeah. So this is the reason why if you are not able to assess all the organs of the baby properly, like it must be done, even if you pick a defect that you are very familiar with, you still have to refer to fetal medicine so that fetal medicine can verify and make sure that there are no other associated defects which you may not be able to satisfactorily rule out. So do not say this is simple until you have done everything on the baby, including checking their heart in detail. That's when you can say, look, this is just an isolated defect. So this is why every defect has to be referred to fetal medicine, even if it is as simple as probably maybe mild ventriculomegaly, you still have to refer because there could be other associations which we have to look for. Then follow up every 4 weeks to monitor the evolution of the lesion. Delivery, again, you want these babies to be delivered in a place with intensive care and pediatric surgery. Delivery timing, 38 weeks. As you can see, that most babies with defects, the delivery has to be programmed. The reason for this is so that the best hands are on the job when these babies come out. Because if you don't program your delivery, the deliveries may happen at odd hours where there is no good support on the ground and the outcome may not be as expected. So if there is evidence of bronchial obstruction, delivery should be by cesarean section with an exit procedure. An exit procedure, that means the procedure should be done as soon as the baby comes out, right at the operation table. Somebody should come there and help the airway. So this is a delivery which can be arranged together with the pediatric surgical team. The cysts are usually asymptomatic, except if they are obstructing the tracheobronchial tree. Otherwise, they are asymptomatic and there's no increased risk of recurrence. Where am I going? Am I going backwards or what? Okay. Then we have this condition, which in short is called chaos. Chaos, because with the abbreviation it becomes CHAOS, so we call it chaos. It's as common as 1 in 50,000. Again, not very common in fetal medicine terms. But what happens is that there is an agenesis or a stenosis of a segment of the upper airway at the level of the trachea or larynx. So we did the bronchial where we said one side is obstructed, but in this case, the obstruction is at the upper airway, which involves the trachea of the larynx, sometimes the pathology behind could be some laryngeal cyst or a laryngeal worm. It becomes evident after 16 weeks of gestation. So it's a condition we should be able to pick at the 20-week anomaly scan. The lungs are massively enlarged or inflated and are hyper-echogenic, resulting in the compression of the heart and development of ascites. The heart normally appears a very tiny structure as pushed towards the anterior wall. In this condition, the bronchial tree is dilated and the diaphragm is inverted. Inverted means the diaphragm is sort of pushed downwards and the convex part of the diaphragm is facing the abdomen instead of it facing the lungs because of the over-distension due to the obstruction of the upper airway. Upper airway obstruction causes lungs to inflate, to over-inflate. This is why things look like this. The incidence of chromosomal abnormalities is not increased. Genetic syndromes are found in in greater than 50% of the cases. The most common is Fraser syndrome, which is an autosomal recessive. When you are saying something is autosomal recessive, that means it has a 25% chance of being passed on to the next to the next generation, or occurring to the next in the next pregnancy. Then what is Fraser syndrome? It's a syndrome where we have small eyes. Small eyes is what you call microphthalmia, and there is a facial cleft, and also the trachea atresia, which is responsible for the chaos, and the bilateral renal agenesis and heart defects, and synedactyly or polydactyly. So these are quite, detectable ultrasound scan abnormalities. So always remember what we did with the syndromic approach and the MIMS, Mendelian Inheritance in Men website, which helps us to work through the syndromes and know which syndrome we are dealing with. But this is Fraser syndrome. This is how it presents. Detailed ultrasound examination is required. Then the fetal MRI could help in the identification of the location, the type of the obstruction. If the pregnancy is continued and a couple do not choose termination, serious scan should be carried out to define the best time for delivery based on the evolution of the hydrops. Like we say, the hydrops come from the impairment of the venous return, and the baby starts swelling, and also the compression of the cardiac vessels due to the hyperinflated lungs. Again, delivery, hospital with intensive care and pediatric surgery. The timing is 38 weeks. So that means babies like this should not be delivered anyway. You transfer in utero. You don't say, I'm going to deliver and send the baby. That's a disaster. Delivery is 38 weeks. Cesarean section with exit procedure and tracheostomy. So when you are saying exit procedure, that means the guys, the pediatric team, surgical team, have to be in theater during the delivery, and they have to pass it to do a tracheostomy because there's no way this baby is going to be able to breathe. So please take note of this, that you don't say, well, let's go and deliver this baby, and then we'll call the neonatologist. The neonatologist may not be able to help you here. You need the upper airway managing team, and they have to be in theater. You don't say, well, we're going to deliver the baby first, and they'll come and see the baby. They have to be in theater when you start to cut, as you cut the woman, so that as soon as the baby comes out, they work on the baby before you have even tied the umbilical cord. So this is very important to remember this. It's a highly lethal condition with almost all cases dying in the neonatal period. There are few case reports of spontaneous resolution in utero, either because of dilatation of a stenotic segment between the larynx and the trachea, or even development of esophageal fistula with drainage of the bronchial fluid in the esophagus. So this is one of the reasons why surveillance of the condition is an option for couples, because some couple may not accept the termination of the pregnancy. So just know that for this couple, they have an option to wait. They have an option to see how things evolve. So we should give them that benefit. Then the recurrence risk is not increased. And with Fraser syndrome, it is 25%, like I've already highlighted, because it's an autosomal recessive inheritance according to the Mendelian inheritance pattern. Then we have CPAM. CPAM is the same as what? There's another word for CPAM. Anyway, I'll remember it probably before I finish. But CPAM is congenital pulmonary airway malformation. It's fairly common in fetal mated terms. We've already seen some cases, both pulmonary and extrapulmonary lesions. It's just common as 1 in 4,000. So that means it's fairly common. We can potentially see 100 cases a year locally because we deliver around 400,000. So fairly common. How do we identify? We normally see a high echogenic tumor in the fetal chamber. Tumor is not equal to cancerous. Some may think, so it's a cancer. No, tumor just means it's a lesion. It's not cancerous. It usually presents after 16 weeks gestation. It can be divided into both solid or microcystic or macrocystic with one or more large cysts, and mixed with areas that are solid, intermixed with areas containing multiple cysts of less than 2 centimeters in diameter. So this is the lesion, the condition which you need to distinguish bronchial cyst from. So we have bronchial cyst, then we have CPAM, which is congenital pulmonary airway malformation. So CPAM can also be called CCAM as well, congenital cystic adenomatous malformation. So when you are reading and you see something called CCAM, just know that it's one and the same condition. But it can also be called congenital cystic adenomatous malformation, and that's CCAM or CPAM. The lesions can be pulmonary or extrapulmonary, by the way. So the lesion is unilateral in about 95% of the cases, and usually involves one lobe or a segment of the lobe. Eye drops is found in about 10% of the cases. Polyhydramnios, due to compressed or obstructed esophagus, may present at greater than 26 weeks. So surveillance is key for this condition because we know how the condition may evolve. This is why this knowledge is important, so that you don't tell people we had patients we had kind of follow-up plans. Say you see a woman with CPAM at 18 weeks, then you told them, we'll see you at 36 weeks to see how things are. You don't do that because you know that the condition can evolve. Associated abnormalities, the instance of chromosome abnormalities and genetic syndrome is not increased. The defects in other systems, mainly cardiac, renal, or tracheoesophageal fistula, are found in about 10% of the cases. Again, I emphasize, if you pick up one lesion, please don't think you've finished your work. The rest of the systems have to be checked properly. If you are competent in checking the rest of the system properly, you refer to fetal medicine, fetal defects clinic, so that we can check properly all the systems and make sure this is an isolated lesion. Then fetal therapy, thoracoamniotic shunting may be useful in case of a large cyst causing major mediastinal shift ascites. So that is draining the cyst. If the cyst is huge and is compressing thick, drainage may be required. In few cases of eye drops, open fetal surgery with the excision of the lesion has been carried out with relatively good results. Yes, there are groups who are actually doing these operations whereby they check out the baby, remove the cystic lesion and close the baby's thorax and put the baby back inside, and the pregnancy continues. There is also some evidence that maternal administration of steroids may cause shrinkage of the lesion and resolution of the drops. That is a high dose of prednisolone, which may go as high as 60. Then ultrasound plan every 4 weeks to monitor growth and the lung lesion and amniotic fluid volume. During the early third trimester, greater than 80% of the macrocystic lesions resolve. This is why surveillance is important. This is why it's important. But in 80%, in greater than 80% of the cases, this is not a true resolution, but purely inability to detect the lesion by ultrasound scan, because the normal lungs also become echogenic. The lesion can be detected postnatally by chest X-ray or even better by CT scan. This is indeed true. We have followed up women, I think some in the private sector, where these kind of lesions, which were not seen after delivery. And ultrasound scans didn't find anything. So yeah, so it is possible that they may resolve. Then delivery, hospital with intensive care and pediatric surgery, the delivery timing is 38 weeks. Then if there is evidence of poor growth of fetal hypoxia, then delivery may be done early. Induction of labor aiming for vaginal delivery is a good option. And if there is no eye drops, the delivery is very good with CCAM, with CPAM or CCAM. Then it's usually lethal if there is eye drop. So eye drops is never a good thing on a baby. Any baby who develops eye drops, these tend to greatly reduce their survival chances. No increased risk of recurrence, and the association of chromosome abnormalities is very low. And these couples, there may be no need to offer them karyotype, really. Diaphragmatic hernias. I think we've seen quite a couple of them now. As common as 1 in 4,000. How do we know that there is a diaphragmatic hernia? The abdominal viscera herniate into the thorax through the defect in the diaphragm, with associated deviation of the heart from its normal position. Bowel, stomach, and liver may be in the thorax. And if it is left-sided, it is left-sided in about 80% and right-sided in about 15%. And the posterolateral anterior retrosternal in about 5%. Polydiagnosis occurs after 26 weeks in most cases of congenital diaphragmatic hernia. Associations, chromosomal defects, mainly trisomy 18 or 30, and occasionally tetrasomy 12p, tetrasome of the short arm of chromosome 12, or Pallister-Killian syndrome. Are found in about 20% of the cases. Then we also have genetic syndromes, which are found in about 10% of the cases. The most common one is Fryns syndrome, which is an autosomal recessive. The moment you hear the word autosomal recessive, then you should know that the recurrence risk is 25%. How do we identify this one? Anophthalmia. Anophthalmia means absent eyes. We have seen a baby with anophthalmia already in our unit where there were no eyes. So don't say that these conditions do not exist. They do, where there is absence of the orbits, right? So anophthalmia, fascial cleft, micronathia, ventriculomegaly, and diaphragmatic hernia. All these are conditions which are identified, which we have already come across. So again, syndromic approach, and also using the NIMS, which is inheritance in men website, will help us to know whether we have Fryns syndrome or not. Then defects in other systems, mainly craniofacial and cardiac, are found in about 20% of the cases. As you can see, congenital diaphragmatic hernia is main associations, and there is need to make to carry out a detailed examination of the baby, including fetal echocardiography. Amniocentesis for karyotyping. Then the CVS is not appropriate for pallida Killian. And when you do the karyotyping, we also need to do the when you do the amniocentesis, besides ordering the conventional karyotyping, we also need to do a chromosome microarray. In these days, I think we can go further and maybe do whole exome sequencing as well, to try and look for many of those other defects. Then assessment of severity is the measurement of the contralateral lung area in transverse section of the chest. Then we divide that lung area by head circumference in what's called lung head ratio. The measure lung head is compared to the lung head ratio in normal babies. And the disease is classified as severe if the ratio is less than 25%, moderate if between 26 to 45%, and mild if greater than 45%. I'm hoping we have some images in our file where we'll be able to show this, how this is done. Then ultra-fast MRI may be useful for accurate assessment of proportion of the liver found in the thorax. And so these lung head ratios are the basis for cancelling of the pregnancy care plan, to say, do we continue or do we offer the couple expectant management as a viable option, or we offer them termination of pregnancy as the most viable option for them? This is based on the lung head ratio, to say weigh lung head ratio. Fetal therapy. There is some fetal therapy which is being practiced in other countries. I think South America, that's where they do it. Europe and Americas, they are doing it. Even Asia, I think it's only in Africa where we haven't started doing fetal. Fetal means fetoscopic endoluminal trachea occlusion. As we have already learned, that obstruction of the trachea causes the lungs to hyperinflate. So it has been noted that if we block the lung, where the lung side, where the diaphragmatic hernia is, or the trachea per se, we are going to cause both lungs to hyperinflate so that the lungs grow. Was compression of the lungs by the contents of the abdomen, the abdominal contents, will cause the lungs not to grow because it's compressed. But if the balloon is put inside and the lungs hyperinflate, this will allow the lungs to grow and give the baby a fighting chance after birth to be able to breathe. So this is how it works. So how it works is that through endoscopy, this is an in utero procedure when the baby is inside. An inflatable balloon is put inside the trachea, so that the baby can, the lungs can retain some fluid and expand and stimulate the growth. The balloon is inserted around 26 weeks and removed endoscopically around 34 weeks. The studies are still ongoing. Randomized control trials are being done, but this is a procedure which is being now done quite routinely in Europe and Americas. And however, patient selection is very key whenever this is being done. Ultrasound scans every 4 weeks to monitor lung growth and amniotic fluid volume. And amnio drainage may be necessary if there is polyadamnios and cervical shortening. Risk of fetal death is about 5%. Delivery, hospital with the neonatal intensive care and the pediatric surgery. The timing is 38 weeks. The delivery could be earlier if there is evidence of poor growth or fetal hypoxia, and the induction of labor aiming for vaginal delivery is the method preferred or method if there is no obstetric indication. Then the prognosis, if it is part of trisomy 18, it is lethal. Then if it is isolated, survival is less than 15% for severe disease, those less than 25% of the lung head ratio. For those between 25 to 50, which is the moderate, it's 50% and 90% for mild disease. So calculating the lung to head ratio is very key in counseling these the couples with where the baby is this condition. Morbidity in survivors include developmental delay in up to 30% of cases. Especially in those requiring ECMO. ECMO means extracorporeal membrane oxygenation. These are babies whose lungs are failing to manage the oxygen situation, and they have to get oxygen through this procedure. Then gastroesophageal reflux in about 50% of the cases, unfortunately, and scoliosis in about 10%. So all this information is key in counseling the couples. Then there is no increased recurrence risk if it is isolated. Part of trisomy, again, 1%. Always remember this, when trisomies are involved, recurrence risk is 1%. Part of syndrome, 25%. Like we said, that it's autosomal recessive, so it's 25%. I think I'll end with lung hypoplasia so that I can continue next week, and I can also attach some pictures to show you. So lung agenesis or hypoplasia is common as 1 in 50,000. Complete absence or hypoplasia of one lung, usually the right one, with major mediastinal shift. Again, it's not a very common condition. The incidence of chromosome abnormalities is not increased. The association of hypoplastic right lung with hypoplastic right pulmonary artery and partial pulmonary venous drainage of the right lung into the inferior vena cava is referred to as Schmitter syndrome. Schmitter syndrome. So whenever we have abnormal pulmonary venous return, we should always think of Schmitter syndrome. This is why when we are doing a fetal echo, we check for the pulmonary veins, where we say are the pulmonary veins draining, or we ascertained their presence. The reason is we know that there's a condition called Schmitter syndrome. So when you suspect Schmitter syndrome, just examine the lungs carefully. Then detailed ultrasound examination include echocardiography because of the Schmitter syndrome, which we mentioned. Then ultrasound scans every 4 weeks to monitor the evolution of the condition. Then we have to deliver at a place where there's a neonatal intensive care and a pediatric surgery. Yeah, so I think I'll stop here. Okay, delivery is 38 weeks, and induction of labor in vaginal delivery is recommended. Prognosis is worse for right than left lung agenesis, probably because of greater degree of heart and mediastinal displacement. In Schmitter syndrome, mortality is about 10% due to severe pulmonary hypertension, and there is no increased recurrence risk. So I think I'm thinking of stopping here, because I feel like I probably will need to show you pictures next week to complement what we have done, so that I'll finish the rest with the images. So I'll stop here with what we have covered so far. I think we've covered a lot. Yeah, so I don't know, I will open the room for questions. If there are any burning questions, you are more than welcome to ask those questions. Or alternatively, we can always share the questions in the group. Yeah. So I'll end here, and thank you for attending. Enjoy the rest of your weekend, and we'll meet again next week to continue on thoracic and abdominal lesions and lung lesions. So yeah, otherwise, bye-bye.